nervous system. So, and also we had discussed few topics in the medicine part as well. So the last session we were talking about Glasgow-Coma scale. So, and also the test for confirming brain death. So moving on to today's discussion. So firstly, we have a MCQ to solve. So statement 1, fasciculations are characteristics of lower motor neuron lesions. Statement 2, Babinski sign is seen in the lower motor neuron lesions. Options are option A, both statements are true. Both statements are true. Option B, both statements are false. Option C is statement 1 is true, statement 2 is false. Option D, statement 1 is false and statement 2 is true. So the answer is option C. Fasciculations are the characteristics of lower motor neuron lesions, whereas Babinski is not related to lower motor neuron lesions. So we'll see what. So firstly, we have a MCQ to solve. And upper so statement 1, fasciculations are characteristics from this lower motor. As in the previous session, lesions. I also showed statement you 2, which are the main Babinski topics that have been seen in the lower motor. So this was one lesions. Among them. So options are option A, both statements that you can remember. True. Both so statements are true. Option B, stable. Both statements are false. So here you can option C is statement 1 is true, statement 2 is false. Of the muscle, option D, statement 1 is false. Lower motor neuron lesions. 2 is whereas true. Upper motor neuron lesions, the wasting of muscles is very less. The answer is so option C. Fasciculations are the characteristics of are present more lower in motor neuron lesions, whereas Babinski is not related to lower motor neuron lesions. Hypertonia is upper motor, flaccidity is more to do with the lower motor. Spasticity, whenever there is spasticity, is upper motor. US. So remember a mnemonic US. US is upper motor spasticity. So lower motor you have more of flaccidity. Okay. So Babinski is absent in cases of lower motor neuron lesion. So coming to the next MCQ. So patient with a cervical cord injury develops hypotension, bradycardia, warm extremities, and what is the most likely diagnosis? So patient has come with a cervical spinal injury followed by hypotension, bradycardia, warm extremities. So what could be the diagnosis? First one is septic shock, cardiogenic shock, neurogenic shock, hypovolemic shock. So it is very clear here there is an injury to the spinal cord. So here we can rule out septic shock as there is no signs of infection or anything. Cardiogenic shock, here it is very clear. The injury is mainly to do with the nervous system. So there is no blood loss as such. So there is a neurogenic shock. So the answer will be C, neurogenic shock. So again followed by another MCQ. In acute spinal cord injury, the return of which reflex indicates the end of a spinal shock? Option A is corneal reflex and cremasteric reflex, bulbocavernous reflex, plantar reflex. So in an acute spinal cord injury, so which reflex indicates the end of the spinal injury? Answer is bulbocavernous reflex. So coming to another MCQ, a hemisection of spinal cord causing ipsilateral motor loss, ipsilateral loss of vibration, contralateral pain and temperature loss. So there is a ipsilateral motor loss and a loss of vibration, whereas contralateral pain and temperature loss. So this is called as anterior cord syndrome, Brown-Sequard syndrome, central cord syndrome, posterior cord syndrome. So the answer is Brown-Sequard syndrome. So whenever there is a hemisection of the spinal cord, so ipsilateral motor loss, proprioception or vibration of ipsilateral side, the same side of injury, it is related to Brown-Sequard syndrome. Contralateral will be more of pain and temperature. So there's another MCQ. Statement 1. Anterior spinal artery syndrome causes loss of motor function. Statement 2. Posterior column sensations are preserved in the anterior spinal artery syndrome. Okay, so there are both statements. So below are the given options. So what could be the answer here? Both statements are true. Whenever there is an anterior spinal artery in the syndrome, so mainly it causes loss of motor function and posterior column sensations are preserved. We'll see why this happens. So here in the statement 1, you can see that in the anterior spinal artery syndrome, it causes the loss of motor function. So anterior spinal artery mainly supplies the corticospinal tracts and spinothalamic tracts. So you know that corticospinal tract is related to motor pathways, whereas the spinothalamic tracts is related to the pain and temperature. So any infarction in this causes paralysis or weakness below the lesion. So you can also experience loss of pain and temperature sensation. So coming to the statement 2, posterior column sensations are preserved. Why? Because posterior columns are supplied by the posterior spinal arteries. So hence vibration, proprioception, fine touch, all these remain intact. Okay. So this is the reason both the statements are correct. So coming to next MCQ, a patient presents with resting tremor, rigidity, bradykinesia. So patient presents with resting tremor, rigidity, bradykinesia, shuffling gait. The lesion is most likely involves cerebellum, corticospinal tract, extrapyramidal system and posterior columns. So there is a tremor, rigidity, bradykinesia and shuffling gait. So it is related to extrapyramidal system. So extrapyramidal system controls the posture, muscle tone and automatic movements. So any lesion here produces rigidity, tremors and abnormal involuntary movements. Already a few of the things we have already discussed. So lesion in a particular part of the brain causes what kind of symptoms. So this will help you in solving this MCQ. So in the previous MCQ, we also saw posterior columns are related to what? Corticospinal tract is related to what? So motor system is not affected here. It's more to do with the extrapyramidal system. So answer is extrapyramidal system. So here you can see pyramidal tract and extrapyramidal tract lesions. So in the pyramidal tract, it mainly affects the corticospinal tract. So extrapyramidal, it is mainly to do with the basal ganglia and cerebellum. So if you see the symptoms what were present in the previous MCQ, it kind of resembles the Parkinson disease as well. So again, Parkinson's mainly affected as basal ganglia. So that is why extrapyramidal affects cogwheel rigidity. Again, this is something we see in the Parkinson's disease. So again, Parkinson also can come under extrapyramidal tract disease. Spasticity. So spasticity previously we saw in upper motor neuron lesions. Okay. So involuntary movements are mainly present in the extrapyramidal tract. So tendon reflexes in pyramidal tract, they are exaggerated. So again it is related to the corticospinal tract, motor movements. So mainly voluntary muscles are involved in cases of pyramidal tract. So extrapyramidal tract, there is no paralysis. Okay, Babinski sign is positive in the pyramidal tract. So match the following extrapyramidal features with their lesions in the with their lesion sites. Okay, so list 1 are the signs that are given. So list 2 is which region they are related to. So what could be the option here? So we know resting tremor. It is something related to which part? Resting tremor. substantia nigra. So from here we can try to solve here. Again, chorea is something related to subthalamic nuclei. Okay. Chorea is related to the caudate nucleus. Hemibellismus is related to subthalamic nuclei. Resting tremor is related to substantia nigra. Dystonia is related to globus pallidus. So in the neurology, if you know what structure in the brain, what function it does, it will help you in solving the MCQs, and it makes it much easier, I can say. So next MCQ, loss of vibration sense and consciousness of proprioception below the lesion suggests the involvement of spinothalamic tract, corticospinal tract, posterior column, spinocerebellar. So already we saw spinothalamic, corticospinal, what it does. So corticospinal is related to the motor system. Okay. So in this way the answer is the posterior column. So again, sensations carried by the posterior column. So posterior column is again supplied by the posterior spinal arteries. So posterior column is related to the fine pitch. Okay, fine pressure, vibration, joint position sense. So whenever there's a lesion in the posterior column, there is loss of fine touch, loss of vibration sense, loss of joint sense. So hence there will be a positive sign of Romberg sign here, and also sensory ataxia, loss of joint proprioception. Okay, followed by another MCQ. A patient has a loss of pain and temperature sense on the right side below the T10. So the lesion is most likely involving the right posterior column, left spinothalamic tract, right corticospinal tract, and left posterior column. See, in this session, I'm mainly trying to teach the topic through MCQ so that it does not cause more of theory session kind of a thing. So as well as you are active in this kind of session. Okay, for your reference, there's an image as well. So patient is presenting with loss of pain and temperature sensation on the right side below T10. So the lesion is most likely involving the which of these tracts? Answer is left spinothalamic tract. Okay. So here you can see there's a crossover which happens in the spinothalamic tract. Okay. So fibers will cross within one or two spinal segments. So the tract lesions always produce the pain and contralateral pain and temperature loss. So in the Brown Sequard syndrome also we saw there was a contralateral pain and temperature loss. So there is spinothalamic column involved here. So coming to the sensations which are transmitted by the anterolateral column and spinothalamic tract. So anterior spinothalamic tract mainly involves the crude touch and the crude pressure. So lateral spinothalamic tract mainly involves the pain and temperature. Spinothalamic, loss of touch, pressure. Okay. So this was the same thing, anterior and lateral. A cape-like, the cape-like distribution of sensory loss and syringomyalgia because of the lesion commonly affects the lumbar cord, thoracic cord, cervical cord, sacral cord. Okay, syringomyalgia. First, we need to know what is syringomyalgia. So this image, you can see that there is a pig. There is some opacity here. Okay. So in the translucent part, there is some opacity which you can see here. So syringomyalgia is a condition in which there is a fluid-filled cavity. So it is also known as syrinx. So which forms within the spinal cord. So it is very common in the cervical region. Okay. So fluid-filled cavity inside the spinal cord. So the answer is cervical cord. So most common region is cervical cord. So classical pathophysiology of syringomalacia. So coming to the classical pathophysiology. So whenever the syrinx is expanding, it causes damage to the anterior white commissure and also to the crossing fibers of the spinothalamic tract. So this causes loss of pain and temperature. So previously we saw what is the function of spinothalamic tract, both anterior and lateral. So you can correlate here. Pain and temperature is getting affected, whereas fine touch, vibration, proprioception and all is preserved. So this is called dissociated sensory loss. So classical sensory loss, cape-like distribution. So that is nothing but loss of pain and temperature over the neck, shoulders and upper limbs. Because again it is involving the cervical spinal segments. Okay. So it is commonly affected here. So why this happens? Why there is a fluid accumulation in the spinal cord? Okay. So the syrinx first expands in the central spinal cord and compresses the anterior white commissure, crossing fibers. So this carries nothing but the okay, again posterior column we saw they are untouched. Okay, posterior column remains intact. So this selective loss of same thing that what we discussed in the previous slide, nothing but the dissociated sensory loss. Okay, so this is about syringomalacia. Moving on to the next topic. Okay, Argyll-Robertson pupil. Argyll-Robertson pupil. So here what happens is pupil constrict during near vision or accommodation, but do not constrict to light. So pupil are constricting whenever there's a near vision or something they have to concentrate or focus on something nearby, but it does not constrict to the light. So whenever they are exposed to the light, pupils do not constrict. Okay, so causes are mainly it is associated with neurosyphilis, and other causes could be diabetes mellitus, multiple sclerosis, and midbrain lesions. Okay, so midbrain lesions, pectoral region. So this is the region whenever there is a lesion in a midbrain, especially in the pretectal region. So this can cause Argyll-Robertson pupil. Okay. So next you have another MCQ. Loss of corneal reflex with preserved facial movements suggests there is a lesion of facial nerve, trigeminal nerve, ophthalmic in the trigeminal optic division, glossopharyngeal nerve, optic nerve. So here we can see what to say. So coming to the optic nerve, what is the function of optic nerve? So again, functions of the cranial nerves becomes important here. Okay. When you see facial nerve, it is something it helps, whereas to raise the eyebrows, close the eyes tightly. So if at all you see facial nerve palsy, you can correlate. It is mainly to do the muscle movements. Okay. So then next is, later we'll discuss the trigeminal. Going to the glossopharyngeal. So glossopharyngeal is something related with the tongue, mostly tongue, throat, all these things. So in this way, we can rule out glossopharyngeal nerve. Optic nerve. Again, when you see the function of optic nerve, it is mainly to do with the vision. That is pupillary response. Okay. Pupillary response, and also from this will also help in telling us the visual acuity. Okay. So next is trigeminal nerve ophthalmic division. So here is the one that causes the loss of corneal reflex, whereas the facial movement is present. So another important topic as we are talking about trigeminal nerve is the trigeminal neuralgia. Okay, so it is a sudden severe facial pain along the distribution of the trigeminal nerve. So trigeminal nerve is the fifth cranial nerve. So most commonly involved division is maxillary, mandibular. Okay, whereas ophthalmic division is very less commonly affected. First one is maxillary, followed by mandibular. Lastly, or very less likely to be affected is ophthalmic division. That is about trigeminal neuralgia. So coming to our next MCQ. Most common vessel compressing trigeminal nerve in the trigeminal neuralgia. Bacillary artery, anterior cerebral artery, superior cerebellar artery, and vertebral artery. Okay. So why this trigeminal neuralgia happens? So whenever there is a compression of this trigeminal nerve root, one cause. Okay. So this compression of trigeminal nerve root by the superior cerebellar artery. So other causes could be multiple sclerosis, tumors, and brainstem lesions. So multiple sclerosis we already saw even in the Argyll-Robertson pupil also. It is one of multiple sclerosis also causes this Argyll-Robertson pupil. Okay, so here it is, there is compression. So mainly superior cerebellar artery. So here you can see pain which suddenly starts when washing or while shaving or cleaning the tooth, that is brushing, eating, talking, exposure to cold. So this exposure to cold is a common thing that we see even in the PDs. Okay. So here another MCQ, a child presents with mask-like face, inability to smile, and impaired lateral eye movement since birth. So most likely diagnosis. So Bell's palsy, myasthenia gravis, Moebius syndrome, trigeminal neuralgia. So this is how the child appears to be. Okay, this is a reference image for this condition. So here already we discussed trigeminal neuralgia. So myasthenia gravis also you're very, it's a common thing that you have commonly we have seen myasthenia gravis. What happens? Bell's palsy as well. So the answer is Moebius syndrome. So again when you see in myasthenia gravis, mainly you will see ptosis of the eyelids, diplopia, and fatigability of the eye you can see. So in this way where there is permanent changes, it is mainly to do with the Moebius syndrome. So what happens in Moebius syndrome? It's a rare congenital non-progressive neurological disorder. Okay, it's a rare congenital disorder wherein the cranial nerve 6 is getting affected. Okay, and also cranial nerve 7. So the main features of cranial nerve involvement is facial paralysis, masked face, inability to smile. Masked face is nothing but expressionless face. Okay, and also inability to smile, poor facial expression, difficulty closing eyes. Cranial nerve 6 involvement, you can see failure of eye abduction. That is what lateral movement was difficulty in the case scenario what was given, and also strabismus. So in cases of infants, you will see poor sucking, feeding difficulties will be there, drooling, lack of facial expression. Okay, this is about Moebius syndrome. You have another question, MCQ. a patient with Bell's palsy is unable to close the affected eye. So this predisposes to cataract, corneal ulceration, glaucoma, retinal detachment. So firstly, we need to know what is Bell's palsy. So it is a very common condition we also see in the OPDs. It is an acute lower motor neuron facial nerve palsy. So wherein there is sudden weakness of muscles of the facial expression on one side. Okay. So occipitofrontalis muscle of face is responsible for wrinkling on forehead as bilateral innervations of the facial nerve of both sides. Hence, wrinkling on the forehead is preserved in the upper motor neuron lesion. So, how you can differentiate Bell's palsy of lower motor neuron lesion and with an upper motor neuron lesion? Okay, so you will see absence of wrinkling on the forehead in cases of Bell's palsy, whereas in the upper motor neuron lesion, you can see wrinkling present. Okay, so mainly what you can see here is corneal ulceration. Okay, so why corneal ulceration is mainly because the improper as the eye is not able as the patient is not able to close the eyes properly, they are more prone for corneal ulceration. Okay, so symptoms of Bell's palsy. Symptoms firstly, it's a subacute onset in a few hours. So causes could be idiopathic, viral, trauma, cold exposure, and vascular damages. So it is mainly associated with pain in the face or around the ear, followed by loss of movement on one side of the face. Mouth deviates to the healthy side. Taste in the anterior two-thirds of the tongue is diminished. Hyperacusis, drooling of saliva, or failure to close the eyes if attempted. Or else there can be upward deviation of the eyes when patient tries to close it. So this is Bell's sign. So hyperacusis means increased sensitivity to sounds. So ordinary sounds appear excessively loud and painful for them. So next topic of discussion is bulbar palsy and pseudobulbar palsy. So this is also an important topic along with the upper motor and lower motor neuron lesions. So bulbar palsy. It is caused by the lower motor neuron lesions of cranial nerve 9, 10 and 12. So here you can see palatal and pharyngeal muscle weakness, tongue weakness. So if you know the functions of these nerves, it is very easy to tell the symptoms of the bulbar palsy. So cranial nerve 9 helps in the shrugging of the shoulders. Okay, it is also sorry 9 is nothing but a glossopharyngeal nerve. Okay, so glossopharyngeal nerve already we saw it helps, it mainly affects the mouth, tongue and also the pharynx. So palatal and pharyngeal muscle weakness you can see, tongue weakness which leads to the tongue deviation or protrusion to the same side of the lesion, and dysarthria you can see absent gag reflex. So 10 is again a vagus nerve. Okay, gag reflex, mainly to do with the vagus nerve. So second is, the 12th nerve, cranial nerve is the hypoglossal nerve. So inability to, it affects mainly the movement of the tongue. Okay. Coming to the pseudobulbar palsy. So which occurs due to the damage of corticobulbar fibers. So these are supplying to the cranial nerve 5. That is nothing but trigeminal nerve. Seventh is facial nerves. Okay. Seventh is facial nerve. Nine, nine again, it is glossopharyngeal nerve. Then is vagus. 12, you have hypoglossal nerve. So gag reflex is getting affected here. Again, tongue spasticity causing spastic dysarthria and leads to the opposite side of the lesion. Brisk jaw jerk. Donald Duck voice. As if patient is trying to squeak out the words from tight lips. Emotional liability. So these are pseudobulbar palsy symptoms, signs and symptoms. Okay. So moving on to the next topic, that is infections of central nervous system. So most common causes of bacterial meningitis. So in the neonatal, you can see more of group B streptococci. Okay. Neonates, globally neonates can be affected by group B streptococci. Whereas in India, you have mainly Klebsiella, which is followed by Staphylococcus aureus, and lastly E. coli. So child you have pneumococcus. Adults again pneumococcus. Adults in epidemic situations you have meningitis. Coming to the MCQ, CSF with increased neutrophils, high protein and low glucose is most suggestive of viral meningitis, tuberculous meningitis, pyogenic meningitis and multiple sclerosis. So these are the options. Answer is pyogenic meningitis. So here you have a table. It is good to remember this table as this will help in solving the MCQs. So here you can see viral meningitis. So in viral meningitis, protein is normal. Okay. So in this way, you can rule out viral meningitis. Tubercular meningitis, protein is increased up to 100%. Okay. So coming to the low glucose. Again, there is a low glucose. So here in tuberculous meningitis, mainly lymphocytes are increased. So in this way, you are ruling out tuberculous meningitis. So pyogenic meningitis, you have neutrophils, high protein and low glucose. So glucose is increased in cases of tuberculous meningitis. Sorry, decreased. So next MCQ, predominant lymphocytes with low glucose and high protein and CSF suggest tubercular meningitis. So in the previous table, we already saw this tuberculous meningitis. Okay. So which CSF finding is characteristic of viral meningitis? So options are neutrophilic, phagocytosis with low glucose, lymphocytic predominance with normal glucose, very high protein with cobweb clot, RBC predominance. Answer is lymphocytic predominance with normal glucose. So you have important points here. Moderate meningitis or nothing but the recurrent meningitis. It is an aseptic meningitis. It is also called as benign recurrent lymphocytic meningitis. So CSF will show large endothelial cells and polymorpho neutrophils. Okay, so most common of meningitis in each patient is Cryptococcus neoformans. CSF electrophoresis is done in multiple sclerosis. So here you can see immunoglobulin present. Okay, oligoclonal IgG bands. So most common cause of viral encephalitis is herpes simplex. Most common of viral encephalitis in India is Japanese B encephalitis. So in general, if they are asking, it is more to do with herpes. So in India, in particular, when asked, it is Japanese B encephalitis. So moving on to another MCQ. Assertion, CSF and herpes simplex encephalitis may show RBCs. Reason, herpes simplex encephalitis produces hemorrhagic necrosis of temporal lobes. Option A, both A and R are true, and R is the correct explanation of A. So both A and R are true, but R is not the correct explanation of A. Option C is A is true, but R is false. Option D, A is false, but R is true. So when you see herpes simplex virus encephalitis, it mainly causes the hemorrhagic temporal lobe necrosis. So leading to which you can see the RBCs in the CSF. So the option is A. Both A and B, assertion and reason are true, and R is the correct explanation of A. So you have another MCQ here. A patient presents with seizures, and CT brain shows ring enhancing lesions with eccentric dots. Most likely diagnosis is tuberculoma, brain abscess, Neurocisticercosis, glioblastoma. Okay, so this is the imaging, what you can see. So there is a seizures in the CT brain. We are seeing ring enhancing lesions with eccentric dots. So you can see dots. Okay, so what could be this? So this is a case of Neurocisticercosis. It's the most common parasitic infection in CNS and a major cause of acquired epilepsy, especially in the developing countries. So pathology, what happens here is larvae. Larvae form the cyst in the brain parenchyma, mostly brain parenchyma. Also they can also form in the ventricles and subarachnoid spaces. Answer is Neurocisticercosis. So coming to the clinical features, you have seizures, so headache, vomiting, raised intracranial pressure, focal neurological deficits depending upon the position of the cyst. Hydrocephalus also can be present. So most common sites of Neurocisticercosis is first is parenchymatous, interventricular, subarachnoid, spinal orbital. So most common presentation is focal seizures. Imaging, so ring enhanced lesion with eccentric dots. So the appearance is like hole with dot appearance. So most common primary malignant tumor in adults is meningioma, astrocytoma, glioblastoma, multiforme, medulloblastoma. Okay. So most aggressive or high grade tumor is astrocytoma. Okay. So the most common primary malignant brain tumor is glioblastoma multiforme. So first of all, the aggressive kind of a tumor is an astrocytoma. Astrocytoma is nothing but the glioblastoma multiforme. Okay. So now astrocytoma is also called as glioblastoma. So it is a very aggressive and a malignant tumor. So when you see the imaging of this tumor, a butterfly glioma crosses the corpus callosum is typical for glioblastoma multiforme. You can see a butterfly kind of a shape. So answer is glioblastoma multiforme. In order to be more specific, it is glioblastoma multiforme. Tumors of the brain. So the most common brain tumor is secondaries. Core cell cancer of lung, cancer of breast, malignant melanoma. Most common malignant brain tumor is glioma. Most common benign brain tumor is meningioma. So malignant is glioma, benign is meningioma. Cause of leptomeningeal metastasis is CA of breast. So most from question perspective, remember incidence of metastasis is more in meningioma when compared to astrocytoma. Glioblastoma is a type of glioma. Coming to the pediatric brain tumors. So the most common malignant tumor in children is medulloblastoma. So brain tumor with worst prognosis in children in the brainstem is glioma. Most common benign brain tumor in children is caryngopharyngioma. Malignant is medulloblastoma. Benign is caryngopharyngioma in children. Brain tumor that can be visualized on X-ray skull is caryngopharyngioma. So due to the calcifications. Okay. So coming to match the following. Neurofibromatosis type 1, neurofibromatosis type 2, tuberculous sclerosis, von Hippel-Lindau syndrome. So option C, neurofibromatosis type 1 is optic glioma. Neurofibromatosis type 2 is schwannoma. Tuberculous sclerosis, astrocytoma. Von Hippel-Lindau syndrome is hemangioblastoma. So here you can see the syndromes and which nervous system is getting affected. So the tumors formed in the nervous systems. Okay. So we will also discuss about neurofibromatosis type 1 and type 2 in the further slides. So this is a small table. It will help you in solving any kind of match the following can be asked from this topic. Pseudotumor cerebri. So the most common, okay, before discussing into the topic, we'll just try to solve this MCQ. So most common cranial nerve palsy in the pseudotumor cerebri. Option cranial nerve 3, cranial nerve 4, cranial nerve 6, cranial nerve 7. So the answer is cranial nerve 6. So we'll see what is this pseudotumor cerebri. It is also known as idiopathic intracranial hypertension. So it is a condition with increased intracranial pressure. So normal imaging, no actual brain tumor. It mimics symptoms of brain tumor. So hence the name pseudo tumor. So young obese women with headache. Most common. Young obese women with headache. So clinical features when you will see mainly headache, vomiting, transient visual scurations, blurred vision, pulsatile tinnitus, diplopia. Important sign is papilloedema. So this is an image of papilloedema. Cranial nerve involvement most commonly is the abducens nerve, that is the cranial nerve 6. Lateral rectus muscle weakness leading to diplopia. You can see here. So young women presents with recurrent neurological deficits separated in time and space and most likely diagnosis is myasthenia gravis, multiple sclerosis, Parkinson's disease, motor neuron disease. So by now we know what is myasthenia gravis. So what can happen in myasthenia gravis? So mainly here again voluntary muscles are getting affected. Okay, so it improves with the rest, but gets worsen on exertion. So what is multiple sclerosis? It's again an autoimmune condition. So where there is destruction happening, leading to visual disturbances, motor issues, and also sensory changes. Okay, more of emotional and cognitive things are getting affected. Parkinson's, we have seen tremors, all these. Okay. So here we are seeing diseases which are affecting mainly the peripheral nervous system, and also diseases mainly affecting peripheral nervous system and a component of a peripheral nervous system. So multiple sclerosis comes in affecting the component of peripheral nervous system. So again you have acute disseminated encephalomyelitis, Stapes dorsalis, vitamin B12 deficiency, central pontine melanosis, leukodystrophies, Guillain-Barré syndrome is affecting mainly the peripheral nervous system, chronic inflammatory demyelinating polyneuropathy, Charcot-Marie tooth disease, and also copper deficiencies. Answer is multiple